The topic for tonight is longevities of teeth versus implants. And basically, it's a treatment planning session. Nowadays, we all know it's an implant era. It's the implant time. However, I'm privileged enough to come in from a practice that has been saving teeth and placing implants for the past 40 years. And looking back retrospectively at cases that has been completed in our practice, and really scratch our head a bit and bring out that critical thinking behind all these cases. And I hope I can deliver a nice message at the end of the presentation. So our learning objective for tonight is obviously to look at the long-term follow-up with periodontally treated teeth, GTR, osteosurgery, or even no surgery at all, versus teeth replaced with implants. What is the long-term follow-up of that? And obviously focusing on the treatment planning and critical thinking behind all this. The factors intervening in the decision-making process. First and foremost, what is the dental or the endodontic condition that is remaining, and when do we decide if we save or we do not save a tooth? Basically, what is a dental and endodontic condition left? What is the type of edentulation, anatomy of the edentulous site? The treatment difficulties, duration, patient availability and compliance, which is one of the most important things that you should consider if you extract or you keep the teeth. The periodontal condition, proper diagnosis, proper prognosis, obviously treatment plan, controlling the occlusive factors, function, parafunction, and the patient-related condition. Socioeconomic status, does the patient can afford going for implant? Does he want to hold on the maximum to his own natural teeth? The age, which is really critical too, and financial needs. So the treatment planning is based on current concept, saving natural teeth by controlling periodontal and dental disease. I wanted to show you a case that was completed back in 2007. This patient came in with an advanced periodontal lesion. She was suffering from terrible pocket depths, mobility, flaring of the anterior teeth, and a lack of proper oral hygiene. So this patient was only treated with scaling and root planning. And this is it a year later, where even the hiatus or the gap in between the centers were closed by the pressure of the tongue, of the lip. This showing you when you control the bugs or you control the bacteria, you install proper oral hygiene habits to the patient, and just by scaling and root planning, the disease can be reversible. This is in 2010. A very stable result. Take a look on the radiographical level, what's going on. This is in 2006. As you can see, some infrabony defects, obviously diastemas in between teeth, mobile dentition, and just by scaling and root planning, this is it in 2010, still holding the test of time, 4 years later. Many of us young periodontists today will go perhaps quickly and extract these teeth and place implants. Well, give teeth a chance. It's always with proper control of hygiene and proper control of installing good compliance every 3 months, a good scanning and root planning, you could save teeth. Take a look at this case back in 1998. About the same situation. Missing posterior teeth, posterior bulb collapse, advanced periodontal lesions, mobility, pocketing, you name it. This patient was only treated with scaling root planning and proper splinting of the anterior teeth. This is in 1999. Take a look at it on a radiographical level, 1998. You can see here an enormous amount of bone. 90% of the bone was lost. Most of us today would go in, extract these teeth, place 2 implants. Well, give teeth a chance. This is 1999. This is 1 year later. Splinting of the anterior teeth. Let's take a look in the periapical level. 1998, infrabony defects on this molar. Resolution of this defect 4 years later. Just scaling root planning. 1998, infrabony defects, the same. Anterior maxilla, the same. Here on the left side, but the same. Obviously, this root tip was extracted, and the rest healed properly. But the main the area of interest in that case was the anterior mandible. Take a look at this case in 1998 and in 2002, 4 years later. Just by cleaning properly, a proper scaling, proper root planning, elimination of plaque, restoring good oral hygiene habits, 3 months recall, patient's compliance, well, you can save teeth. This is 2007 with the same patient. So about 10 years post-op. Who would save these kind of teeth back in 1998? Well, you saw these mobility teeth, extreme bone loss, 90%. They stood 10 years, and they can stay 22. However, it's never, when you look at Tonetti's studies in 2000, he said after 22 years of treated and well-maintained patient suffering from advanced periodontitis, one tooth, and predominantly a molar, is lost every 5 years. So it's not always a good thing, according to literature. Let's take a look at this case in 2000, mainly focusing on these three areas: the lateral, the premolar, and obviously the molar. Let's start with the molar. As you can see, infrabony defects, 1 and 2 wards remaining. We have placed implant in the edentulous site, grafted with some autogenous bone, and did conventional guided tissue regeneration. This is about 2 years post-op. In the maxilla, about the same thing. We gathered with the rongeur the autogenous bone and obviously changed the profile, did the proper osteoplasty, proper periosurgery. This case was treated with periosurgery and grafting of the infrabony defects, and this is it about 2 years post-op. The anterior tooth, however, the lateral, we didn't do anything, just scanning and root planning. This is 12 years post-op. Perfect, maintainable result. This is the clinical photograph showing an adequate clinical result with proper maintenance. Let's look at this lateral, where many of us would go ahead and extract it with only 3 millimeters left and mobility. This is back in 2000. This is 2012, 12 years later. And this is more recently in 2018, 18 years post-op. That same tooth lasted. And take a look at the radiograph showing 18 years post-op, a 3 millimeter, standing the test of time. Here, a very stable result. So, the determining factors for successful outcomes is 1, proper diagnosis and treatment planning. 2, controlling the risk factors. 3, technical performance, obviously. You have to know what you're doing. And 4 is the patient's compliance with treatment and follow-up. Let's take a look at a patient that did not follow up in the proper way. This is back in 1991, advanced periodontal lesions, infrabony defects, mobility, you name it. The patient did 2 sessions of scaling, ran away. This is 1995. You have an advancement of the lesions. This is 2001. So the patient lost teeth. The disease is advancing. We're not controlling the disease. 2002, the patient couldn't handle anymore. This is where we did a full mouth rehabilitation using implants, upper and lower, and this is it 10 years later in 2012 with stable result. So as soon as the patient probably took his wallet and started to pay for implant, he started to come for regular maintenance. And this is showing you that even a patient that was not on good maintenance and had advanced periodontal lesion, when placed with implants and replaced with implants, with the proper maintenance, we had stable result at even 10 years. And this is the clinical situation 10 years down the line. So, the longevity of implant-supported reconstructions. Implants have been used widely in dentistry for the past 35 years. And we've had many successful 10-year follow-up on these implants. If you name the studies, you can take a photo of this slide and look it up on the internet. You have a lot of studies showing successful 95, 96% of implants on long term. Even back in 1992, they had excellent success rates, back with the old machine-surfaced implant. Obviously, implants are a great alternative. However, they don't come in without complications. You have a biologic complication, you have complications from the mechanic point of view, and you have complications, obviously, from functional point of view. In biology, you can have mucositis, peri-implantitis, and this is what they call today the new disease in implant dentistry, and implant loss. In mechanical point of view, you can have a screw loosening, a ceramic chipping, screw fracture, fracture of the metal of the framework, component fracture. So implants do come with complication, even with complication in the phonetic type of complications described by Longevites in '92. So saving teeth versus placing implants. Implants are great, but they do come with complications. So what we look at is that the longevity of implant-supported single crowns versus a periodontally treatment of severely compromised teeth. 3-unit bridge on natural teeth and the single crown on restored teeth. So here, second part of my lecture, I'm going to try to compare the difference between an implant-supported crown, let's say, on the same situation, in a single type of situation, single crown on an implant or on a natural tooth. As far, and then we're going to talk about periodontally treatment severe teeth, or the use of single unit implant versus 3-unit bridge, which is a wide question that we always ask. So let's look into first the implant supported single crown versus the single crown on restored teeth. And this, I want to show you a clinical case, and would like to pick your mind a bit and see a raise of hands. Who in this audience would preserve or extract that tooth? Let's start with preserving. We have 5. How about extracting? 10. Oh, more. Okay, to preserve or to extract? This is one of those questions that we always ask ourselves. If you want to preserve the tooth, you really have to think, especially in that case. This is a case in the anterior maxilla that has, a patient has a low smile line, has an occlusion that is edge to edge, and also wants an immediate type of treatment, wants to have a result immediately. So I'm here sitting with him, I want to preserve that tooth, then I have to think, we have to force erupt the tooth to create properly ferrule effect. We have to crown lengthen that after that. We have to do a new root canal on it, a post and core, and a crown. And all this is time consuming, is costly, and is also related to the patient's age. Now, if I tell you that the patient's 50-year-old, you would think differently than if the patient would be 25-year-old. Obviously, this is how you think clinically. Or if you go and invest yourself into extracting that tooth, we're looking at an immediate implant, immediate temporary, obviously to preserve the aesthetics, preservation of papilla, preservation of aesthetics, it's time and saving, obviously. And if you compare that to all the other series of procedures that you'll be doing, if you want to preserve that tooth, it will be time and cost reducing. And the patient's age also is a very critical factor. Well, you can all guess by now, we did not preserve that tooth. We went for extraction. This tooth was extracted using, obviously, as shown by Dr. Shalash, a very nice presentation, Here we use the exotome and really extracting and taking all our time into extracting that tooth in a traumatic way. First of all, what we do after extracting is properly sound the socket to see where the bone is. If we have enough bone on the mesial, distal side, even palpate the buccal plate to adequately sense that buccal plate of bone to see if we have any dehiscence or not. Here, it's an intact socket, the type 1 socket. A very good socket to place an immediate implant in. The implant is drilled palatal, way palatal, as you can see here, parallel to the palatal plate. Implant inserted with a high insertion torque. The gap is filled in with a proper bone graft. Here used the xenograft. We then proceeded with an immediate temporary that we pick up on a prefabricated shell. We lute it outside of the mouth. We create the subcritical contours and the critical contours and proper emergence profiles. You can see here. And this is inserted less than 1 hour later. So, this or preserving, crown lengthening, forced eruption, root canal, post and core, all these factors, risking a new fracture, or doing that. This is how the patient walks out an hour later. Now, I'm not a proponent of going ahead and extracting all teeth. But here in the decision-making process, it is beneficial for the patient to deliver this kind of treatment. This is a day of surgery, and this is it 2.5 years later with an excellent profile. The patient even got the other central crown. And we have good literature about it. Longevity of implant-supported single crowns is over 96% in many of the review studies. Now let's take another situation. This patient is a 23-year-old with a fractured crown lateral incisor. Would you preserve or would you extract? Now let's see a raise of hand. Preserve? Yes. Extract? More preserve. You guessed it right, because I said extract before. No. So again, the same critical concept and critical thinking. Preserve means forced eruption, means crown lengthening, because we have this, a gingival margin that is below the crown margin that is below the gingival margin. We have to reinforce the feral effect, do a new root canal, a new post and core. But here in this patient, he's 23. It's much worth it. This is how he presented. We went and did a forced eruption on that tooth with a fixed bar bonded to the adjacent teeth. This is 8 weeks into the forced eruption. We then proceeded with a crown lengthening, minimal crown lengthening, to properly recontour the gingival margins. And this is at 5 years post-op. Let's see on a radiographic level, initial visit, 8 weeks, and this is it, 5 years post-op. Obviously, it's a great way also to save teeth, and we all know that the longevity of single unit crowns is way up high in the 90s% too. So this or that, it's really nice to critical think at every single case and presents to your office and try to come up with a nice solution that can last for a while. And now, a good and an interesting point that we should mark out is that teeth that have been endo-treated, according to this review, we have 93% of success rates if there is no pathology. However, we have 79% if there is a pathology. How about the retreatment? 97% if there are no apical pathology at first, a bit less when there is a pathology. Endo is a treatment that we do on a single day. Every day we treat teeth, we do root canal, we do retreatments, and we restore them. It's good also to know the difference between if there is a pathology or there isn't a pathology. Take a look at these root canal treated teeth. This is on long term, 1 to 2 years post-op, and this is courtesy of our endodontist, Dr. Walid Nami. So treating root canals is a good thing, and we should always favor it. However, when we have perforations, the success rates of root canal therapy, again, is much low, less than 40%. Here, for example, we extracted that tooth, replaced with an implant. This is back in 1997 with a great implant. This is 4 years later. Now, a question we always ask ourselves, are we better off doing a 3-unit bridge or a single implant? Well, if you look at the literature, a 3-unit bridge with root canal treated teeth is way low. You have a success rate on a 20-year, is 69%. Whereas you do it on a vital teeth, you have much more success rates. The overall survival rate is about 70%. Obviously, a single unit implant is much better as far as a treatment option. Take a look at this case here. Failed root canal treatment on a molar. The tooth was extracted. The patient refused implant therapy. She went for a 3-unit bridge on a premolar to second molar. This obviously failed. As you can see, a huge post and core that caused a tooth crack later on. These were replaced with 2 single-unit implants. And we can see the longevity of an implant reconstruction is way above 95%. She was better off to place a single-unit implant here. So let's talk about periodontal therapy in the management of severe periodontal defects. We should save teeth, surgically, not surgically, scaling root planning, or even with periodontal surgery. And this is the proof of it. This is back in 1998 with infrabony defects. 1 wall remaining and 3 walls in the distal side. This lesion was treated with a GTR, autogenous bone, collagen membrane. This is it in 2002 with the resolution of the defect, 1998, 2002. Very stable result. So should we treat periodontal teeth? Yes, we can. Yes, we should do it. Take a look at this same patient in the maxilla with a very similar case that we showed before. And here we have a long-term follow-up on it. Also, the same type of situation, cratering, bone defects, periodontal defects. It was properly accessed and treated surgically with the GTR. Autogenous bone mixed with xenograft and a membrane, collagen membrane. This is the suturing. This is 1998. This is 2002. And this is 2018. 20 years post-op. Who would think that this is a salvageable tooth? Back in 1998, they did. They grafted, they waited, they controlled occlusal forces, they controlled the maintenance of the patient, and yet again, a stable regeneration 20 years post-op on this little piece of root. That makes us think that sometimes we should not go ahead and hurry and extract teeth. We should give teeth a chance. This, back in the days where in 1994, they used to do separation. Again, all these cases were treated in our facility, and I have the privilege to have followed up with them. This, first of all, was what they did first was access the horizontal component of this furcation involvement. Grafting was done with the GTR, and as soon as the defect was horizontally controlled, they went ahead and did a separation of the furca and restoration of both single root separately. This is back in 1994. And this is here, 2002. So a long time after that. The 10-year survival rate of furcated teeth, now if you look at the literature, you have, if you follow Carnavale studies, this is back in the 90s, you have very highly success rates of furcated teeth. Again, it's very important to note that in these studies, they did the root canal, they did the pros, and they did the perio. That's why they had really high success rates. If you look at other studies, they have less success rates. And also, we had the same, controversial results. This is back in 1985, where they did furcation and treatment of both of the molar, sectioning the molar, treating separately the two roots. This is 1990, 5 years later, we started to fail. The distal root was extracted. This is 1993. 1998, failure of the mesial root. 1999, extraction. 1999, 2 implants. 2018, 2 implants, and obviously also the second molar was replaced because of fracture. This is 33 years follow-up on that same patient, showing you that teeth stood a chance and lasted for about a good 15 years, and then replaced with implants. Let's talk about, almost finally, let's talk about the longevity of extended bridge on natural teeth. Now, 3-unit bridge has 70% chance of succeeding at 20 years. How about extended bridge? There's a big tendency when you go into clinic, you see these long span bridge from second or third molars to the first premolar. Do they last? Well, they don't. On a 20-year perspective study by D. Baker, evaluating 236 short spans and 86 long span, they found out that the long span bridge, they were less than 60%, 52% success rate. This is on 20 years. They don't last. You should replace them with implants. Don't go ahead and try to do heroic attempts. Today you have a tool that is predictable, that has been proven, and that can last the test of time. I see a lot of these cases in my daily practice. So second molar or third molar attached to a premolar. Third molar, second molar, second molar, and then a long span bridge. These are obviously dependent on they get caries, they get fractured, so it's not a good option. Let's focus here on the right side of the patient where we extracted and sectioned the bridge. We replaced with 2 dental implants. This is implant placement. Comes in 6 months later. I see a very weird, it's not really clear on the screen, socialization around the implant. And let's start, to panic as it is. It's periodontitis. The patient did not have any pus. The lesion was more or less sterile. So for me, it was just a remodeling of the bone, of the cortical bone. This is at 6 months. I didn't do anything. I let it heal, and this is 2 years later with a self-regeneration process without even touching the patient. So it's a good thing to properly diagnose the case here. Is it periodontitis or is it just bone remodeling? This is bone remodeling. This is 2 years later. Okay. Now here, let's take a look here at a study done also in 2011 on 392 patients, where they found out that the major part of the complications were biologic complications, caries, loss of vitality, periodontitis, or even periimplantitis. These were comparing both implant and teeth. Another study here in 2012 showing that the probability to remain free of complication is 79%. This also on the fixed dental prosthesis. About the same rate that we observed in the other study before, close to 70%. Take a look at this case here. This is a case that has been following up in our practice for the past 15 years. He's been restored with dental implants in the maxilla and has this bridge that has been holding on all the years, yet again failing due to periodontal disease, due to bad root canal treatment, secondary decay. Let's look at the periapical x-rays. You can clearly appreciate how you had some caries, you had periodontal involvement, and other teeth that were in bad shape. We decided here in that case to replace obviously this failing bridge with dental implants. So this is the initial situation where teeth were extracted, implants were placed immediately, and we had the socket preservation in the missing sockets. Immediate temporary was delivered to the patient the same day of the implant placement. This is 3 months later, implant placement. This is 3 months later. And this is about 1.5 years later with an excellent aesthetic and functional result. So, in this case, failing dentition, you have the option in your hand, use the implants. And the final case here to pick your mind. Now, this is a 42-year-old patient. He's actually a dentist. He came in with this 2 premolars that had a failing or had a problem with an endodontic problem. What should you do? Should we extract them? Should we save them? These are 9mm length premolars. They have already posts in them. So in order to save them, we need to extract these posts, do new root canals, probably do a crown lengthening on an 8 or 9mm left to create a proper ferrule effect. So obviously you're more or less run out of the length here. So what I proposed to him was to extract these, and we all know how prone these premolars are prone to fracture, even when we restore them in the best of the condition. So what we did was extracting these teeth, also amputating. Here, for example, I extracted the premolars, we extracted the premolars, and amputated the mesial buccal root of the molar, so preserving and extracting in the same time. And we recontoured properly with a good crown lengthening to adequately create the contours and ferrule effect and a good sound tooth structure. This is it in a temporary. This is at a couple months later at implant placement. Both implants were placed in the adequate 3-dimensional position. And this is the final prosthesis in place. And this is the X-ray of it. And this is 3 years later. So, in the same case, we extracted and we preserved. So we should always think and try to, first of all, favor teeth. But if down the line these teeth will not last the test of time, more than 10 years, well, use implants. So, in summary, the cause of tooth loss, is it periodontal? Is it endodontic? Is it root fracture? Should always evaluate the remaining tooth structure, the extent of the previous reconstruction, the post and core buildup, and the strategic importance of that tooth. Never forget the complication. In dental or periodontal, you can have recurrent caries, recurrent periodontitis, root fracture, periapical lesion. This is if it's a bad root canal treated. Or if you're doing it on vital teeth, you can lose vitality. On implants, you can have screw loosening, ceramic chipping, loss of integration, periimplantitis, an abutment implant fracture. So, to sum it up, take-home message is the proper treatment planning based on a proper periodontal evaluation, a proper endo evaluation, a proper prosto evaluation, evaluating risk factors, obviously provide with the best treatment option based on initial evaluation, and never forget, saving the natural dentition should be our priority. Now, this lecture will be on our continuous education website, which is dentlinks.com. I advise you all to sign up, and please feel free to share any comments, and thank you all for your attention.